Okay, Gabriel, you can start now. Thank you.
Okay, well, thank you very much, Elsa, and thank you very much to Betty Lea. And of course, thank you to all of you to be here with me today. Today we are going to speak about orthopedics and traumatology. As Elsa said previously, the goal of today is try to give you as much as tips as possible, because finally with experience we can get some tips and tricks, and then finally we will be better and we will improve faster with these tips. Then I always start with some keys of success. As I already said, the main key is always the experience. This is not easy. Finally, you have to get your experience by yourself, and normally it takes time. Don't worry, because it's normal. Then with this experience, you will be more confident with yourself. And something which is very, very important for me is try to be very methodic, try to do always the same. It doesn't matter if you repeat a lot at the beginning, the same process and the same things, because finally you will be faster and you will diagnose the problems easier and very fast. Then in veterinary medicine, normally we try to look for the same changes, because finally the dogs cannot speak. Then the main change that we are looking for is pain, because if something is painful, is because it's not normal, and is because there's a problem in this joint, bone, or at least the area. Another thing to recognize is any changes in the range of motion, inflammation, muscular atrophy, crepitus, hot or inflamed areas, effusion in the joints, changes in terms of size, like size of muscles, joints, bones, or other things. And finally, the easier one, which is dysfunction. One thing which it was very, very important and very useful for me was to start always from distal to proximal, because it's a way to be methodic. Okay, you can do it as you prefer, but for me, start from distal to proximal is something very useful, because you always do the same. And even if I can give you an advice, if you can even make an orthopedic examination in a normal dog, is useful, because you can recognize the normality, and then when you make an orthopedic examination in a pathologic dog, you will be very fast in terms of recognize where is the problem, and then with experience, even which problem you have in front. Then something very important is start with the less painful to more painful, because if you make pain at the beginning, then the rest of the orthopedic examination probably will be wrong, because the dog is nervous, is under pain, and then if you can start with the less or the non-painful areas, is always better. Even if you know that the dog has a cruciate, leave the joint for the last one. Okay, start with the rest. And always, if you think that the dog has something, and you have a very clear idea in your mind that the dog probably have this problem, leave this problem for the last one, and start methodically with the beginning with your orthopedic examination. Okay. Then, as we know, there's a lot of variability on breeds. There's a lot of sizes, kind of legs, dogs, and even cats. Sometimes the most difficult are the cats because they are very different. I don't know how it's in your country, but here in Spain, the cats are not easy to manage. And then the orthopedic examination, and for sure, if they are in pain, the examination can be very, very, very difficult. Then in these kind of patients, the most important thing will be the observation, okay? Because sometimes it can be pathognomonic changes that then these pathognomonic changes tell us the diagnosis straight away. Let's start with some videos because this is my method. As I said, you can change it, but I always start from the distal area. In the interdigital area, I always check the nails, the toe, and then I start going up, making the palpation on the bones, evaluating the joints, all of the articular range of motions, the ligaments, the collateral ligaments, which they are normally forgot, but it's an important area to check, and then continue going up. Don't forget to make the mid-diaphyseal palpation in puppies because the panosteitis is a problem, and sometimes it's just the palpation, the diagnosis. Then I will explain during the speech a specific test because sometimes it's the main test that we need to do the diagnosis. In the stifle, we have majorly the tibial thrust and the cranial draw. This is the cranial draw, and the tibial thrust is the other one, this one. And then we check the patella luxation, making this movement, varus and valgus with the paw, and trying to luxate the patella. Okay, we will check this again during the speech, don't worry. Now we are on the hip. This is the pectineal palpation. Traditionally, the pectineal palpation is related with hip pain, but at the moment and in the actual times, the pectineal palpation is not very accurate in terms to diagnose hip dysplasia. Finally, there's a lot of tests that we will see during the speech better than the pectineal palpation. The only thing that we can do is just palpate in this area and say if the hip is painful or not painful. But we cannot say if there's hip dysplasia just with this test, okay? Because it's not accurate enough. Then we will continue with the palpation of the bones. Normally we have this triangle, and the distance from the femoral trochanter and the ischiatic tubercle is always the same, and it has to be symmetrical with the other side. Then, if it's not symmetrical, normally we are diagnosing a hip luxation. The most common hip luxation is the craniodorsal, but there's the cranioventral as well. And the one which is very, very uncommon is the caudoventral. Okay, the most common is the craniodorsal, then the cranioventral, and then the caudoventral, okay, which is very unlikely. Then now we are doing the ortholani test. We will check out this specific test, okay, in the next slides. Then I will not spend time at the moment with this, just check it because we will repeat this. And then one important thing is try to check how is the range of motion. Don't lose in your mind that the majority of dogs with normal hips are painful if we try to make an excessive extension. There's a paper which takes that the 80% of dogs completely normal are painful in the hip extension if this extension is too much. Okay, then the pain in the hip extension is not accurate enough in terms of to be 100% sure that the hip there's a problem or not. Okay. Then let's see this this video in the forelimb. We have done the hind limb. Now we are doing the forelimb, the front limb as well. As you see, I start always with the same. It doesn't matter if it's the fore or the hind limb. Always checking the nails, the digits individually, the interdigital area. Then we will continue with the sesamoideus. The sesamoideus bones are very, very important, and they are more important even if the dog go or tend to live in the field, because normally these tiny bones are under this area, and normally if you press with strength enough, you will check that the area is painful. Okay, for example, there's two main breeds very predisposed to this pathology, which is fractures or metacarpophalangeal arthrosis with sesamoideal disease. Okay, this is very common in Labradors and Rottweilers. Okay, and the sesamoideus 2 and 7 are the most predisposed. Okay, then we are going to continue up. Making the palpation on the metacarpal bones. Then we will check for a fusion in the carpus. Then we will test the collaterals, the extension and the flexion, and we will measure the range of motion. We will need to know which is the normal range of motion, and this is why we need to check normal dogs as well. Okay, then. After this, we continue with the palpation and of the radius and the ulna. We will go to the elbow. As you know, the elbow is one of the main joints in the forelimb. Finally, the majority of the problems, or to be honest, the difficult problems to be diagnosed are in the elbow. We have some landmarks. The humeral lateral and medial epicondyle and the olecranon are the main landmarks. In the middle of those landmarks, there's a fossa, and in this fossa is where normally we can find the effusion, okay, which is the main here. This is the area, which is the effusion is the main and the first change that we can find in a dog with, for example, an elbow dysplasia. Then we are going to do the Campbell test. Okay, the Campbell test was done and was thought initially to test the collateral ligaments on the elbow, but at the moment is useful as well in terms of assess the medial and the lateral compartment. Okay, as you saw here, we start with just neutral elbow flexion without touching the carpus, just from this area and with the other hand on the top of the dog, and making fully flexion of the elbow. Okay, then we are going to do full extension like this, and the next step is the Campbell test. The Campbell test is in 90 degrees the elbow. We are going to do varus and valgus of the carpus, and then we are going to repeat this motion doing flexion at the same time, flexion of the elbow. And with this, we will be palpating the medial and the lateral compartment, and to be honest, the area of the coronoid process. Okay, because normally with this Campbell test, we will check those coronoid process, the lateral and the medial coronoid process. Then we will continue with the shoulder. I will show you now. Okay, in the shoulder, we have 4 different compartments as well: the cranial, the caudal, the lateral, and the medial compartment. Okay, in the cranial compartment, we have the biceps tendon and the supraspinatus tendon, and then we go to the lateral with the infraspinatus tendon, then to the caudal with the head of the humerus, which normally we will have OCDs in the caudal area. In the lateral area, we will have pathologies in the supra and infraspinatus, and then in the cranial compartment, we have problems majorly in the tendon of in the biceps tendon. Okay, and then the last compartment is the medial compartment. This is very common in toy breed dogs or small dogs. They normally suffer of the medial compartment disease because the glenohumeral tendon and the suprascapular tendon is affected, and then they have instability of this medial compartment. Okay, now we are going to see how we check it in terms of diagnose the medial compartment disease or not. Now we are checking the extension and flexion of the shoulder, and we continue the examination with the combination of flexion of the shoulder and extension of the elbow. This is called the chest test, okay, and is useful in terms of check the integrity of the biceps tendon. Now we are going to see a dog with a biceps tendon pathology fully disrupted, which in a normal dog, we will have from 90 degrees to 135 degrees. If it's above 135, the dog has a problem. If it's below, it's normal. Okay. Okay, this is flexion. Then we do some rotation. The shoulder is not a joint which is easier to rotate, but we can rotate it as well. And then just continue the palpation of the scapula, the acromial process, the scapular spina, and just palpate everything. Okay. Okay, then we have seen which is a normal and traditional orthopedic examination in a dog. There's a specific exams and tests, and we are going to see those specific exams in the next slides. Then I want to give you my protocol, which is normally the step-by-step that I normally continue. I always start with observation, that's it, which just checking how is the dog walking, then running, and then probably going up and down the stairs. Then I do the orthopedic exam without any sedation. Then I make in my mind the differentials. Then is where I start with the imaging, X-rays, MRI, CT scan, or whatever, and other tests. We will see which tests are those. And then I always recommend to put the dog under sedation and repeat your exam, because sometimes we need to do those special tests which are not possible if it's not under sedation. And with everything, we will have the definitive diagnosis. In the observation, we can see the pathognomonic changes, if they are present, but sometimes not, and the majority of the time they are not present. Then we need to check if the dog is lame or not. Yeah, and it's very important to check if there's any problem more related with a neurological pathology than orthopedic. And this is why an orthopedic surgeon has to know a little bit at least of neuro, because we need to be able to differentiate the neurological to orthopedic pathologies. Then we will go to direct examination, we make our differentials, we make our imaging and test. Don't forget the last one, this is MRI, no MTI, sorry. Don't forget the joint tabs, because as in another problems, if you can do a joint tab, the analysis of this fluid normally will give you a lot of information, because the diagnosis a lot of times is in the fluid, in the examination of this fluid. And then, which is very uncommon, but don't forget to do an electromyography, because sometimes if you don't know what is happening, sometimes it's because the problem is not orthopedic, it's neuro, and then we need to go to MRI, a CSF tap, electromyography, etc. Okay. And well, finally, there's a problem which is very, very common in ortho, and is even more common when the dog is old. Then you can advise and you can diagnose more than one problem. And then there's a decision to do, that we cannot treat everything, because sometimes, the majority of the times, one of them is the most relevant. And then we have to find which one is the more relevant and treat the one more relevant, because the majority of the times, the rest have been there for a lot of time, and the majority of their life. And then we have to check which is the more relevant and treat that one. For example, sometimes we have patients with hip dysplasia, chronic hip dysplasia, lumbar disease, chronic lumbar disease, and a cruciate. We will diagnose all of them, but we need to decide which one is the one that is making the dog lame at the moment. Okay, probably in a case like that, the cruciate is the important. Okay. Then let's start with these videos. This is the specific test with for the hip. This is the ortholani test. What you need to know is that in a dog less than 2 years with an ortholani test positive, the dog will have 90% of possibilities of hip dysplasia in the adult age. Okay, it's important to practice this test because it's not easy, at least at the beginning. It's important to press from the joint, from the stifle joint, and then try to check if the hip have laxity or not. Okay. The second test is the Bardem test, and this is an easier test, to be honest, but it has to be mandatory in under sedation because it's painful. And why is painful? Because in the medial area of the femur, there's the femoral nerve, and then when you press on the femoral nerve, it's painful. Okay, and the goal of this test is the same: is try to check if there is any laxity or not in the hip. Okay. And the last one is the Barlow, is very similar of the ortholani test. And the thing that we do is just press bilaterally towards the table, and then we open one leg and then close. When we open, at some point, the hip will jump inside the acetabulum. And this is the angle of reduction. Then we will close slowly, and at some point when the leg is close to the 0 degrees, we can feel another jump, and this is the angle of subluxation. Okay, then we will have a subluxation angle and a reduction angle. Both angles are telling us how severe is the pathology, and then we will put our focus on the reduction angle, because if the reduction angle is less than 25, the dog is a good candidate to symphysiodesis, juvenile pubic symphysiodesis. However, if the dog is more than 25 degrees, is not a very good candidate. If the reduction angle is more than 45, then the dog has a subluxation, a permanent subluxation, and then is not a candidate for a symphysiodesis or even for a triple or double hip osteotomy. Okay. In resume, the symphysiodesis is from 0 to 25, and the hip osteotomy from 0 to 45. Okay. Let's continue with more specific tests. This is the normal and frequent repetition of the normal and frequent examination of the elbow. Flexion without manipulating the carpus, then the Campbell test, doing varus and valgus, and flexion of the elbow at the same point, okay, and at the same time. Normally, if the dog is painful, we'll try to or cry, try to bite us, or even they try to go away from us because we are pushing, and the push when we push, they have pain, and they try to go as away as possible, because it's the only way that they have to reduce the pain. Sorry. If you see the dog is a Rottweiler, which are very dogs, they are not crying so many times. And if you see when I flex, okay, then don't cry, but they go as away as possible. Let me check the other video. Okay, here we can see the joint effusion in the middle of the landmarks, the epicondyle and the olecranon. And when we do the specific flexion, the dog try to jump and go away from me. Okay. Okay, let's see a specific test on the stifle. This is the cranial draw, which is positive, very easy to do. But the tip here is don't move the hand on the femur, okay? The hand on the femur is always holding, and the hand on the tibia is the one which is moved, okay? And the only thing that we need to know is if the proximal part of the tibia is unstable or not. Okay, anything else? We have not to try to luxate the stifle or be too brave. Is more precision than strength. Okay. And there's more test on the stifle. It's not just the cranial cruciate. The stifle has collaterals as well, and this is how we can test it. Okay, we block the femur and we move the tibia as well as in the cruciate in order to see if the lateral and the medial part of the stifle is unstable or not, and if we are able to open it or not. Okay, in a normal dog or cat, which is in the video, we are not able to open it. Nothing, not one degree. Let's continue with the stifle. This is the test for a patellar luxation. As you see in this video, my right hand is doing movement on the metatarsus. Okay, we are doing a valgus movement, lateral rotation of the paw, and we flex and extend the stifle. And with this movement, as we can see here, we are able to see how the patella luxate and go in the normal position every time. Okay, this is a large breed dog, and this is why the patellar luxation is lateral and not medial, because as you probably know, the toy breeds has more medial luxation, the big breeds has more lateral luxation. And this is a very common image when we have pathology or partial or complete rupture of the common calcaneal tendon. In this imaging, we have specifically a rupture, a partial rupture of the common calcaneal tendon with a preservation of the superficial digital flexor. And this is why the fingers are flexed, but the tarsus is less, is more close to the floor, okay, and is a little bit weak, okay, because the superficial digital flexor is outside the common calcaneal tendon, and this is why sometimes we can have a rupture on the common calcaneal tendon, which is a conjunction of 5 tendons, and the superficial is outside. Okay, let's continue with the shoulder. Okay, we have seen a lot of the specific tests. Let's continue with the shoulder. Here we will see how is test the chest test in a pathologic dog, okay, with a complete rupture of the biceps tendon. As you can see here, we have an ability to make the flexion of the shoulder and extension of the elbow fully, which is not normal, as we already said, okay? And then we are going to go to the medial compartment. In order to test the medial compartment, we block with one hand the scapular at the level of the acromion, and then from the carpus, we make the abduction of the limb, okay? Because what we want to know is how much we can open the leg, okay? In a normal dog, we will have from 40 to 50 degrees. If we take the vertical as a 0 and the horizontal as a 90 degrees. If we have from 40 to 50, this is normal, 50, sorry, and if we have more than 50, normally it's pathologic. Another way to know it is compare one leg with the other one, okay? Because sometimes some dogs can have a little bit more than 50, like 55, 50, 58, but it's not pathologic if it's bilateral. Okay, then we have to know on the table, which is more than 55, pathologic, less than 55, non-pathologic, okay? But sometimes it's better if we compare one leg to the contralateral. Okay, now we are going to start with specific orthopedics evaluations because, as I already said, normally it's very useful is we just check the dog without any contact, okay? In this case, for example, we can see how the dog jumps when trying to walk, because there's a lot of weakness on the hip and on the forelimbs, in the hind limbs, sorry, the back limbs. The dog try to go a little bit faster, and then start doing the bunny hopping. Both hind limbs goes together, and as you see, he is doing even an internal rotation. This is because this dog has hip dysplasia, very severe, with a subluxation bilaterally. Here we have another dog with a very common pathology in big dogs. For example, I don't remember how is the name in English, Boyero de Berna, but well, there's some specific breeds. The Bernese is the main breed, which the pathology is hyperlaxity of the tarsus. This pathology can happen in the tarsus and in the carpus, and normally is autolimitant with some time and good diet. It will fix alone, but sometimes it's not like this, and we need to do some surgeries or procedures. The majority of the times, just growing and with a good diet is enough. Then let's see this dog, which has a pathology in the right hind limb. Okay, I already said this pathology is a pathology in the calcaneal tendon, common calcaneal tendon, but in this case is a young dog which had a cut with a bottle of glass on the common calcaneal tendon, and the tendon was cut partially. This is why we can see a weakness on this tendon and on the right hind limb. Okay, let's check this dog, which is lame on the forelimbs. As you can see at the beginning, the dog is very, very lame on the forelimbs, on the right forelimb, because when he tried to put the step, okay, the step forward, he is doing a movement. Okay, he is putting the head as up as possible, because when they go away from the leg, they decrease the amount of weight of this leg, and this is the leg which is painful. Okay, the same that they're putting on the floor at the time that they try to put the head away from the leg. Let's take this English bulldog, because it's exactly the same. It's the right forelimb, and he does exactly the same. When he put the right forelimb on the floor, okay, make the same movement, trying to avoid the leg close to the paw. Okay. Okay, let's go to this one, because this one is very important. In this video, we are seeing neurological pathology, okay, and this is why I show you this, because sometimes it's not easy to compare and to differentiate if the problem is neuro and orthopedic, okay. In this case, in this part of the video is easier, I think, to see it. We can see how the forelimbs go faster and the hind limbs are very ataxic and go slower. Okay, I will put this part again, because you can see that the forelimbs go very fast and the hind limbs are going very slow and with ataxia finally. This is why the pathology is not orthopedic, is neuro. And this kind of pathology, the neuro localization is normally the cervical area or the forebrain, is something very similar than a wobbler syndrome, but this is a Yorkie. Then with a Yorkshire, they don't have wobbler, but the neuro location is the same, cervical or forebrain. The Yorkie had tumor on the cervical area, a meningioma. Okay, and now we have a very, very common pathology, which is a hyperlaxity, on the carpus bilaterally. This is very common in endocrinopathies. When we, for example, has Cushing syndrome, hypothyroidism, or pathologies like that, diabetes, pathologies like that, okay? As we can see, we have a bilateral hyperlaxity of the carpus. We always have to check if there's any metabolic pathology, and if it's not the metabolic cause, probably we will have a trauma, but it's very uncommon to have a bilateral trauma, okay? Okay, well, let's continue with the hip examination, and more specific in the X-rays, because as I said here and as I put here, the osteoarthritis is the main and the main risk factor. Okay, here we have some of the more common X-rays from the hip. We have the Norberg angle, which the normal is more than 105. If the measurement is less than this, the dog is pathologic. If we have more than 105, then it's normal, and less than 95, the dog is pathologic, and the pathology is severe. Okay, then we have the distraction index. The distraction index is part of the pen hip test. I will explain the pen hip test in the next slide. Then the distraction index is the result of this measurement. We put a circle on the acetabulum and a circle on the head of the femur. Oh, sorry. Then we have a distance of both centers of these circles and a radius of the femoral head. Then if we put the distance of the centers with the R, okay, and make a division, we have a distraction index. The distraction index is always a number in the middle of 0 and 1. Okay, now I will put this distraction index here. Okay, and then if we have from 0 to 0.3, the probability to have hip dysplasia when the dog will be more than 24 months is 10%. We are here. If the distraction index is from 0.3 to 0.7, then we are here. Okay, in this average, from 40 to 60, even 70%, depending on the breed. Okay, and if the distraction index is more than 0.7, sorry, the probability is close to 90%. Okay, to have hip dysplasia when the dog is older than 24 months. And then here we have the femoral coverage, okay, or the acetabular coverage or the femoral head coverage. Then this femoral head coverage or acetabular coverage has to be more than 50%. If it's less than 50%, it's abnormal. This is very easy, and we measure this making a superimposition of the femoral head with the acetabulum. If we see here, we can check this white area, which now I put the same in blue, in order to see how much of the femoral head is covered for the acetabulum. Okay. Okay, and here we have the pen hip. These are the normal radiograph of the pen hip, which is a normal hip extension, a frog projection, and a distraction projection. How we normally do this distraction projection? Well, there's different ways, but the easier one is just to put something in the middle of the legs and make pressure from the stifles to the middle, and with this movement, the hips will go outside. Okay, then we take the X-ray, and what we are doing with this is trying to assess the laxitude of the hips as much as possible, and try to put the hip as far as possible from the femoral head as far as possible from the acetabulum. And then we will measure these measurements, we get the distraction index, and then we get the probability of hip dysplasia when the dog will be older than 24. Okay, this is why we take this projection. And this is my clinical report as an example. When we finish everything in terms of hip examination, I normally do this clinical report. It's in Spanish. I'm sorry because I haven't got time to translate absolutely everything. But finally, if you see in the first part, we have the orthopedic examination at what we saw, okay, before the sedation. Then we have here individually every leg, okay, the left and the right, and we put every test, the Barden test, Ortolani, the reduction angle, subluxation angle, which is the Barlow test, the distraction index, Norberg, and percentage of coverage. Okay. After all of this, we have the measurements, we have the clinical assessment, and then the only thing that we have left is the prognosis and the plan. And here is what we put my plan. If the plan is medical management, surgery, hip osteotomies, juvenile symphysiodesis, or hip dysplasia, or hip replacement, okay, the replacement of the entire hip, okay. Then we are going to go very fast in order to just explain a little bit, because it's a very, very specific and difficult pathology, which is the elbow dysplasia. In the elbow dysplasia, we have something which I normally call the big box, because this big box is full of the pathologies. Inside the elbow dysplasia, we have mainly 4 pathologies: the medial coronary fragmentation, the united anconeal process, the osteochondrosis, the OCDs, and the incongruence of articular congruence. Okay, all of these 4 pathologies are part of the elbow dysplasia. The rest are not part of the elbow dysplasia. Okay, then in the hip dysplasia, the main tests are X-rays. In elbow dysplasia, the main test is CT scan, because we are looking for a millimetrical pathologies and millimetrical changes. Then the X-ray is not enough. If you have the suspicion of the elbow dysplasia, you can go straight away for the CT scan, because probably if you go first on X-rays, probably you will miss a lot. Okay, then a normal dog can have less than 0.5 millimeters of incongruence. If you have more than 1.4 millimeter, then the dog will be lame and will be pathologic. Okay. Then here we have some images of pathologic elbows with coronoid disease. In this case, incongruence. We have here another coronoid disease with sclerosis on the humeral, on the medial humeral epicondyle. Here we have a normal 3D reconstruction with a normal coronoid and with a pathologic coronoid with a fragmentation of the coronoid, which is this little fragment completely away from the main elbow and the main coronoid. With this kind of pathologies, the first step normally is arthroscopy, because with minimal assessment, we can diagnose and treat at the same time. Remember that the only way to assess how is the cartilage is the arthroscopy. We cannot check the cartilage in X-rays, CT scan, and even MRI. The gold standard in terms of assess how is and yes, in which state is the cartilage is the arthroscopy. Okay. Then we are going to see images like this, which we can see the fragmentation here, this tiny fragment, and chondromalacia or eburnation of the cartilage. Here we can see the synovitis, okay? And here we can see, which is called kissing lesion or an OCD. Okay, I will show you an OCD in a moment. Here is the tiny fragmentation, this one outside the body after the coronoidectomy. And here in the CT scan, what we are looking is the OCD, okay, which is this hypoattenuating area. Okay, we can see it here, here, and this is an X-rays. The OCDs are possible to be diagnosed on the X-rays, but the CT scan normally is a lot more useful. And here we see the OCD on the left image, this one, and here is the intercondylar incomplete union of the humeral condyle. Okay, the incomplete union of the humeral condyle is a pathology which is outside the elbow dysplasia, but is normally affecting the elbow, but is not part of the elbow dysplasia. This is very, very important to recognize it. Then don't forget the joint tab, because the analysis of this liquid normally is diagnostic. We can diagnose septic arthritis, degenerative disease, or immunomediated disease on the joint. Okay. And just to give you the last tip is from the stifles, because the cranial cruciate is a very, very, very common pathology, and the easier way to diagnose the cranial cruciate is the cranial drawer, the tibial thrust, and the X-rays. In a stifle, we don't need CT scan or even MRI, which is the gold standard in humans. With those tests positive and with effusion and osteoarthritis, 95% of the dogs will have a cranial cruciate disease, partial or complete. Okay, well then the main treatment, as you probably already know, is the TPLO at the moment. Okay, there's a lot of treatments, but the main is the TPLO. Okay, then let's finish the speech with the assessment of osteoarthritis. Probably you will see some of this is in Spanish, but don't worry, if you want to learn a little bit of Spanish, this is a good opportunity. But I will tell you absolutely everything. Then, as we know, the osteoarthritis of the degenerative disease of the joints is a condition based of the inflammatory state, in which the joint start with a degenerative process, which is painful and which never stop progressing. Then we have to, first of all, recognize it, with these radiographic changes: osteophytosis, enterophytosis, synovial effusion, periarticular inflammation. We can have subchondral sclerosis. We have seen this on the elbow, on the CT scan. Periarticular and intraarticular mineralization, and which is less common, subchondral cyst. Okay, the key of this assessment is to know and to be aware that the osteoarthritis is not bad, is the way of the body of stabilize and try to make the best as possible, but it's something which is not useful for the joint and for us, because finally it's degenerative and it's painful. Okay, and it will guide us to chronic inflammation. And then this is why we need to find a solution for this chronic and chronic inflammation. Okay. Then, if we check in the liquid, on the synovial liquid, we will to go here which is the percentage of neutrophils, because normally in a normal joint, we will have less than 5% of neutrophils and more than 95% of mononuclear cells. Then, as soon as we start with inflammation, the percentage of neutrophils increase and the percentage of mononuclear cells decrease. As you see, if we have an infection, septic arthritis, we will have 90 or even more percent of neutrophils and almost nothing of mononuclear cells. Okay, and if we have osteoarthritis, we have the majority of them will be mononuclear and a little bit of increase of these polymorphonuclear cells, which are the neutrophils. Okay. Then, well, finally, we need an orthopedic strategy, because we need a treatment strategy, because we have a lot of treatments to do. We have medical treatments, we have surgeries, we have nutraceutical treatments, we have painkillers, we have infiltrations, anti-inflammatories, physiotherapy, control weight, laser therapy, a lot of things. And then finally, what I want to give you as a tip is try to evaluate every patient individually, because every patient needs a different thing. Then it's true that we need to simplify, and we try to simplify as much as possible. But look, the majority of the patients need a different treatment, and the majority of the times the family have different needs. Then we try to adapt our treatment of our patient and our family. Okay. Then, as we know, we have a lot of treatments. We have the traditional chondroprotectants, we have anti-inflammatories, exercise, analgesics, which are the painkillers, physiotherapy, control weight, and infiltrations. And in the chondroprotectants is where we want to point our focus, because we have been 20 years without any progress. And this is why Betilea is presenting in the last years the Resol Mega, because the Resol Mega is a very good product. Finally, with the Resol Mega, what we have is a painkiller and an anti-inflammatory, which is natural, and we can give to our patient this anti-inflammatory for the rest of their life, which is safe and is useful. It's a medication which is coming from humans, and it has a lot of studies. Then we have to start thinking in why the joints are painful. The majority of the times is for two reasons: for the inflammation and for the degenerative disease. When the cartilage is completely with a erosion, with an eburnation, very well, almost complete, with an eburnation, almost 100% of eburnation, the subchondral bone is exposed, and this is why the joint is very painful, because this causes a massive inflammation, and we need to treat this acutely and chronically. And this is why we have this table and this diagram, because we need to have high impact treatments, which, if you see, opioids is obviously one of them, NSAIDs is obviously one of them. But if we continue looking for more treatments, we see that the omega-3 and the physiotherapy and the support care and the cold therapy is a part of this high impact if we know how to do it. Okay? And then another question is, what do you think? The nutraceutical treatments are useful or not? Because if we see in the past, the majority of them are not very useful, but the only thing that we need to do is check the ones who are useful and the ones that are not. Okay, and then it's true that the traditional ones, which are from the collagen, are not very useful, but the ones from the omegas, okay, and the fat acids are more useful than the traditional ones. And with Resol Mega, we have a different molecule, which is the proresolvina. This molecule has been very studied, and finally is very useful in terms of interfere in the inflammatory scale, because it has the ability of interfere in a lot of steps, in this inflammatory scale. And finally, it has a lot of power in terms of decrease inflammation, improve the synovial liquid, and improve the health of our joints. Okay. Then this probably will be everything for today, because we have almost more or less 1 hour. Now, if you have any question or any doubt about the speech, you can tell me, because I am here for you all. Or if at some point in your future you have questions, doubts, or whatever, you can write me a message. I give you here my professional Instagram, because if you want to ask me everything, I will be open to you. And then if you have question now, I am ready.
So for the questions, you can open the microphone or write on the chat. Or if it's in Lithuanian, I will ask Aphrodite to translate, please.
Yes, Elza, mėlyje, jeigu kas nors turite klausimų, tai galite išsijungti mikrofoną ir paklausti tiesiogiai, arba galite rašyti į chatą. Jeigu atsiras vėliau klausimų, galite mums juos užduoti elektroniniu paštu ir mes paskui persiusim kolegoms. Yes, Elza, you can talk.
Well, Gabri, I think there are no questions at the moment, so I will thank you again for your time. Thank you for all the explanations, and if there's any questions coming by email or whatever, I will just let you know. Okay.
Okay.
So,
well, thank you very much, and thank you all. As I said, if at some point you have any question or any doubt, just let us know. Thank you to the team of Betilea for the opportunity to join everybody in this webinar. And well, thank you.
Thank you.
Okay. So Aphrodite, now I can continue with the summary of the results with the neuro.
Yes, Elza, it's time for you, and after that it will be talk Rolandas.
Okay. So thank you. A very short presentation, because the presentation from Gabriel was quite rich in content. I just wanted to explain a little bit the results of the clinical utility study that we performed with Betilea Neuro CDP in 3 areas: one in cognitive dysfunction syndrome, in ophthalmology, especially in retinopathies and glaucoma, and the third area is neuropathic pain. As you know, Betilea Neuro CDP is a neuroprotectant that contains a nucleotide, which is citicoline, and B vitamins, and it helps to keep the nervous system in good condition, because it's a precursor of phosphatidylcholine, one of the main phospholipids in the cells, and also help in neurotransmission because it's a choline donor. We have performed a clinical utility study with the pet parents that have used Betilea Neuro CDP, because some of their vets recommended the treatment. So basically it's under the veterinarian supervision. And as I said, in 3 therapeutic areas. cognitive dysfunction syndrome, glaucoma, or retinopathy, and neuropathic pain. And how we did this study in Spain? We have of course we work with the vets, but then we have the contact with the pet parents, and we asked our customers or our final customers with Vetiliano CP about the well, we basically wanted to evaluate the changes in behavior in different areas. For example, orientation, sleep-wake cycle, altered social interaction, um, anxiety, level of activity, and learning skills alteration. And we asked how Vetilea neurotherapy helped in these 6 areas. Also, the degree of improvement with Vetilea neurotherapy, the time that it has taken for the pet parent to notice this improvement, and also the level of satisfaction of the pet owner with Vetilea neurotherapy. So basically, it was a survey asking all these parameters. So if we start with cognitive dysfunction syndrome, 20 pet parents answered. So 65 in 65% of the cases, it was better orientation, the main area where they noticed the change. As you can see, they could answer several of these areas. It was a multiple choice, right? So that's why it's more than 100%. And also more activity and playtime and more interaction with pet owner. This improvement was big to moderate in 55% of the cases, and the 45%, the rest of the was slight. It took mainly more than 1 month to notice, and the satisfaction was quite high. So 85% from satisfied to totally satisfied with the product. Then in glaucoma and retinopathies, 38 pet parents answered the survey. So again, 60.5% noticed better orientation, 39.5 more activity and playtime. Those were, and then the next one was better sleep. The improvement was big to moderate in 73% of the cases. It took more than 1 month to notice the improvement. And again, they were very satisfied with Vetilea neurotherapy. So what we see with this product, that there is a very high adherence to treatment, because it's an easy treatment. They don't have any adverse events, and basically we see a very high level of recurrence on the product. And then in neuropathic pain, 9 pet parents, answered the survey. And in this case, it's the most what they notice the most is that there was more activity and playtime, and then better orientation and better sleep. The improvement was big to moderate in 89% of the cases. Again, it's more than 1 month basically to notice the improvement, and the satisfaction was very high. The level of satisfaction was very high with the product. Basically, I'm summarizing. Vetilea neurotherapy is a neuroprotectant, and we have it in 2 formats: in tablets and in a gel. Tablets is dedicated for medium to large breeds, and the gel is for cats and small breed dogs. And it helps improving the quality of life of dogs in neuro patients, basically helping them improving orientation, improving sleep, and recovering the level of activity, play, and social interaction with the pet owner. And thank you very much. This is all from my side. I don't know if you have any questions that I can answer. Otherwise, I will pass the word to Rolandas.
Thank you, Elza, so much. It was very interesting. And kolegos, jeigu turite kokių tai klausimų, galite užduoti, jeigu ne, tai lauksime elektroniniu paštu. Ir jeigu nėra daugiau klausimų, tai labas, Rolandai, kur tu?
Labas.
Labas, nu va, prisijungiai, gerai. Tai nežinau, tai turbūt perleidžiam žodį tau, neužlaikyk čia tų mūsų kolegų, tai taip greitai glaustai tada.
Jo,
Okay?
labai greitai. Matot prezentaciją?
Aš tai kol kas nematau.
Man rodo, kad šerina.
Nesimato nieko.
Nematau, tikrai, žinok, Rolandai nėra.
To.
So,
Dabar?
Jau kraunasi. Super, viskas, matom.
Tai va, labai trumpai.
Pasididink gal, Rolandai, žinok, nes rodo bendrą tokį vaizdą. Kad full screenas būtų.
Jo, dabar, nes man tai rodo full screeną.
Nežinok, rodo visą bendrą tą.
Tuoj bandau dar kitaip. Čia su Google Meetais nepripratėmės. Va, dabar tikriausiai.
Nieko nematau.
Gal sakau, man turi suteikti hostingą?
Kad Elza patvirtint turi.
Gal, nežinau.
Elza, are you here still?
yes.
Rolandas
So you-
can't share his screen. I don't know. Maybe
You have to go to. You have
Yeah.
to go to. Yeah, like this. Okay, that's fine. Now, if you put it in presentation mode,
Let me check.
if you go, I can see your screen. So if you go down at the low bar, at the
Now,
below
okay.
bar, and then you click on the presentation mode, which is the one with the screen.
Can you see my presentation now?
Yeah, I can see it,
In
but it's
presentation-
yeah. It's not in presentation mode, but I can see it.
Yeah, but I would like to show it in presentation mode.
So if you go back to, so if you click in the low bar, in the bar below, okay. So if you
Yeah, sharing. Now
sharing, and then you go to window, right?
Yeah.
Window, and you share and you click on the presentation.
Okay, let's. Yes, I did it. Okay, I see Windows with our meet, and I see
And then-
Windows presentation.
And then you click on the presentation and you click on share.
Yeah, I did it.
Okay, and now if you put it in presentation mode, it should work. Otherwise,
It's happening.
Are you clear? It's strange. Otherwise, if you go back again, you can put on, instead of share window, if you put share on entire screen. I don't know if you try that.
Let me try. Okay. Yes, it's the entire window. Yeah.
Entire
Sure.
screen. Let's see if it works like this. And then you put the presentation.
Yeah.
And you do the presentation. Okay, now.
Super, Rolandai, pagaliau.
Okay.
Thank you, Elza, for help.
You're welcome.
Okay, thank you. So, tai trumpai, tema begrūdis ir su grūdais pašaras, kurį pasirinkti. Šiaip kiekvienas sausas šunų pašaras be baltyminės receptūrinės dalies turi būtiną ir augalinę receptūrinę dalį. Tai pašarai su grūdais įprastai savo sudėtyje turi tokius grūdus kaip kviečiai, kukurūzai, miežiai, avižos, ryžiai, soja. Tuo tarpu begrūdžiai šunų pašarai savo sudėtyje grūdų neturi. Tai juos receptūrinėje dalyje dažniausiai pakeičia turtingi skaidulinių medžiagų alternatyvūs angliavandeniai, tokie kaip bulvės, saldžiosios bulvės, žirniai, avinžirniai, pupelės, lęšiai. Čia mano išvardinti yra dažniausiai naudojami, bet gali būti ir kitų. Jeigu kalbėti apie begrūdį pašarą, tai begrūdis pašaras turi tokius privalumus, kaip kad lengvai virškinamas, tai ypač aktualu, jeigu šuo turi jautrią virškinimo sistemą ir jautriai reaguoja į tam tikras grūdinės kultūras. Šis pašaras yra mažiau alergiškas, tai vėlgi susijęs su tuo pačiu potencialiu alergizavimu kažkokiems tai grūdams. Ir iš principo begrūdžiai pašarai yra aukštesnės kokybės, aukštesnės kainos lygio ir šiame segmente yra didesnis ir įvairesnis aukštesnės kokybės pašarai vien dėl to, kad ir baltyminė dalis pas juos yra turtingesnė ir aukštesnės kokybės. Tuo tarpu prie trūkumų išskirčiau tai, kad iš principo yra didesnės kainos pašarai ir turi daugiau gyvūninių baltymų ir tai svarbu atsižvelgti, ar tai tinka šunims, kurie turi potencialių problemų su kepenimis. Jeigu kalbėti apie pašarą su grūdais, tai pašaras su grūdais irgi yra viskas ok, jeigu šuo nėra alergiškas grūdams, tai grūdai irgi yra puikus angliavandenių šaltinis, kuris suteikia būtinos energijos ir pašarų su grūdais iš tikrųjų yra labai didelis asortimentas, kainų lygis yra mažesnis, bet vėlgi tame dideliame asortimente svarbu tinkamai susiorientuoti ir rinktis maksimaliai aukštos kokybės pašarus, tai yra tuos, kuriuose nebūtų kviečių, nes kviečiai dažniausiai yra tie grūdai, kurie potencialiai sukelia alergijas šunim iš visų grūdinių kultūrų. Tuo tarpu pašarų su grūdais trūkumai yra tai, kad vis tik gali sukelti alergiją dėl glitimo netoleravimo. Pašarai turi su grūdais ir daugiau kalorijų nei kiti alternatyvūs angliavandeniai. Ir tai yra svarbu atsižvelgti į su nutukimu turinčių problemų šunims. Ir kaip ir minėjau, didelis pasirinkimas pašarų su grūdais, tai čia labai svarbu susiorientuoti ir išsirinkti tinkamos kokybės. Šiek tiek trumpai apie kviečius ir kviečių glitimą, nes jeigu kalbėti apie pašarų su grūdais, tai patartina vengti kviečių, nes kviečiai yra tie grūdai, kurie potencialiai sukelia alergijas, tai vėlgi kviečiai gali sukelti tokius netoleravimo simptomus kaip pilvo pūtimas, viduriavimas, vėmimas, pablogėjusi odos būklė, tai reiškia sausa, pleiskanota, plaukų slinkimas ir tai veda į komplikacijas, tai yra į svorio kritimą, nesugebėjimą jo priaugti, gyvūno nuolatinis nuovargis, silpnumas, sumažėjęs gyvybingumas, jautrumas netgi tam tikroms infekcijoms dėl susilpnėjančios imuninės sistemos. Ir labai svarbu stebėti šuns svorį, nes jeigu netoleruoja šuo, tarkim, grūdų, tam tikrų grūdų, dažniausiai tai gali būti kviečiai, tai tiesiog nes organizmas nesugeba pasisavinti reikiamų medžiagų ir šuo praranda svorį. Kaip suprasti, ar šuo alergiškas kviečių glitimui, tai vėlgi, kaip ir minėjau, svarbu atsižvelgti, tai ar šuo viduriuoja, ar kokie gali būti, tai galima imti tam tikrus kraujo tyrimus, šlapimo tyrimai dėl inkstų būklės, odos tyrimai dėl niežėjimo. Jeigu ši lentelė iš principo rodo pagrindinius skirtumus tarp pašarų su grūdais ir pašarų be grūdų, tai vėlgi angliavandeniai, su grūdais kviečiai, kukurūzai, ryžiai, mėdžiai, avižos, rugiai, kaip minėjau, venkim kviečių. Pašarų be grūdų yra alternatyvus angliavandeniai, tai yra bulvės, saldžiosios bulvės žirniai, avižirniai, pupelės, lęšiai. Alergijos sukelimo tikimybė, tai pašarai su grūdais yra didesnė, vėlgi dėl kviečių, be grūdų yra žema, angliavandenių kiekis grūdiniuose yra didelis, pašarų be grūdų yra mažesnis, virškinamumas tai vėlgi dėl tam tikrų netoleravimo glitimo, alergijos glitimui, virškinamumas gali būti probleminis pašaruose su grūdais, pašaruose be grūdų tinka ir jautriam virškinimui, kainos lygiai su grūdais žemesnė, be grūdų aukšta. Čia vėlgi dar tik trumpai noriu paminėti, kad buvo abejonių, ar pašarai su grūdais nesukelia tam tikrų širdies ligų, nes 2018 metais Amerikos Food and Drug Administration gavo pranešimų ir pradėjo tirti atvejus dėl šunų išsiplėtusios miokardijos. Tai buvo įtarta, kad tam tikri šunų pašarai be grūdžiai blokuoja arba nepadeda šuniui užsitikrinti reikiamą taurino kiekį ir tai gali įtakoti šuns veiklą. Tai buvo padaryta nemažai tyrimų, bet vis tik neįrodyta, kad tai yra kažkokia tiesioginė sąsaja. Iš principo galima teigti, kad pašarai be grūdų yra visiškai saugus. Tai čia tiesiog toks niuansas kartais, ką aš girdžiu savo darbinėje praktikoje, kad žmonės pašarų be grūdų kartais bijo ar vengia, nes yra galvė būtent apie tokį atvejį. Trumpai apie mūsų kvatro. Tai vėlgi mes prieš paleisdami rinką produktą darome rimtus tyrimus, testuojame, tai yra žiūrime ėdamumą, kaip kinta svoris, jeigu svoris buvo per didelis ar eina link idealaus svorio, jeigu buvo per mažas ar eina link idealaus svorio, žiūrime kokia odos ir kailio būklė, koks virškinamumas ir visą tai irgi susijęs su pašaro tinkamumu gyvūnui, su toleravimu, kad nebūtų kažkokių alerginių reakcijų ir kol mes nepasiekėm tam tikrų KPI-sų, mes į rinką nepaleidžiame savo produkto. Tai irgi labai trumpai savo kvatro asortimente, galbūt jau ir mūsų kolegos iš švedų jau yra minėję, bet šiaip turime pakankamai platų asortimentą be grūdžių pašarų, tiek skirtų mažų veislių šunim, tiek all-breedinių, tiek didelių veislių šunim. Kai kurie produktai yra pas mus ir monoproteinai, tai yra visiškas vienas baltymas, įskaitant tiek baltyminę dalį, tiek ir net riebalinę dalį. Tai mūsų begrūdės linijos privalumas yra dry meat coated, tai reiškia, kad kiekviena granulė padengta su šaltyje džiovinta mėsa, kas duoda labai gerą ėdamumą. Full source'as, tai reiškia, kad mes naudojame visą gyvūną, tame tarpe ir raumenų mėsą, kaulus, kremzles, organus, kas irgi atneša tam tikras visiškas natūralias vertes, skatina raumenų, sąnarių ir kremzlių atsinaujinimą, ką mes ir netgi prieš tai minėjom, yra labai svarbu. Ir begrūdžiai pašarai, tiesiog nenaudojame tų grūdų, naudojame alternatyvius grūdams angliavandenius, tai yra burokėlių minkštimas, saldžiąsias bulves. Taip pat savo asortimente turime ir pašarus su grūdais, bet čia pabrėžiu, kad yra be kviečių. Tai irgi produktai skirti tiek šunims, tiek katėms. Turime ir su paukštiena, ir su ėriena, lašiša. Tai vėlgi bendrai paėmus yra platus asortimentas tiek pašarų be grūdžių, tiek ir su grūdais. Kad svarbu, jeigu ir su grūdais, tai be kviečių. Tai aš labai trumpai, daugiau netrukdysiu viso šio vakaro laiko ir dėkui už dėmesį.
Tai ačiū Rolandai labai. Ir ką, iki rytoj susitiksim darbę. Ir ačiū visiems prisijungusiam, kas buvo atkantrus, tie apie 150-160 dalyvių, kurie laikėsi, išklausė. Ačiū Jums ir iki kitų susitikimų. Viso.
Viso.